I was just wowed by his mind. He was a meditator and meditated several hours a day. He got it in his head that he was going to meditate on this bench, which was kind of, I call it a perch. I hear this, thud, and I jump up and run over. His head didn't actually have an impact on the outside that was visible, it was on the inside. It created such a small bleed that it was hardly noticeable. The only reason I even knew is he was wearing shoes and there was a noise, and I looked down and I said, "Honey, your left leg is dragging." And the doctor said, "Go to the hospital right away." They told us that he had a subdural hematoma. He went into surgery the next morning. They said it went well. They were very positive about it. We were in the hospital for 13 days, and it felt like some things were clearly going well and other things were clearly not going well. We would report that, he'd had another chest spell, or his arm was numb again, or he had pain. That was followed by what was later called a grand mal seizure. They ran test after test, more CT scans, a chest scan, all day for hours. And then Yogi Raj looked at me and said, "It's happening again." And we get to ICU, and the woman who's in charge of the room says that they think there's probably a blood clot. And she just said, "This doesn't usually go well, and he could die." I could tell that they were, they really, really wanted him to be okay. And he wasn't. A couple of months later, we got the autopsy report, and I poured through it, and I actually set up an interview with the doctor who performed the autopsy. And part of it was about, was the blood clot visible? Was this conclusive? And he said it was absolutely conclusive. This was a complication of hospitalization. It wasn't because of his original traumatic brain injury. A lot of the things we were reporting are, in fact, indicators of a DVT and a PE. It's the most common cause of preventable hospital death. In my mind, more could have been done for sure. Compression socks. He did have the electronic version of it during the surgery and that day when he came back into the ICU. But the next day he started PT, they came off and they never went back on again. So I don't think it was just not on my radar. I don't think it was on anybody's radar. I've spoken about this with medical professionals, and I hear the same thing every time. "I'm really glad you didn't say what hospital it is, because I'm gonna leave this room wondering if it could have been mine." I really miss him a lot. He was my angel when he was here, and he's my angel now. Good morning. It's not easy to follow that video, and I'm guessing that it's not easy to watch given where you're sitting and knowing that probably every day, or at least most days of your life, you're in the situation that my husband's caregivers were in. People ask me, how can I do this? How can I come and stand here and tell this story again and again? And I can tell you that the reason that I can do that is because I know with 100% certainty that every single person who was caring for my husband over those 13 days wished him well, and they brought a lot of skill and a lot of competence and a great deal of, they had their heart in the game. It was evident to me. And when I learned, and I won't go into the story of how I really came to this understanding, but I did come to an understanding that they, like me, had really no place for their suffering. That it was very, very likely that when they learned of my husband's death after those 13 days of caring for him, they most likely felt some level of grief. And I want to propose to you that if you want to stop the clot, you'll want to probably also look at other places where you have accumulated grief or accumulated, what is a clot? But it's an overcompensation for a wound in most cases. I know that's not the only way that a clot forms, but so today as you listen to our story, I want you to remember one thing, and that is that I'm here to help, and I don't feel like anyone should have any shame in being human in their jobs. Most people don't have the courage to sign up and go into fields where their work actually impacts life. So just that courage alone is enough from my perspective for you to remember what you've done well and to have that be uppermost. And at least for me, if I want to take on a really big, audacious goal, I need to remember what I'm doing well to face what I may not be doing so well. So I'm going to invite you and all of those who are listening elsewhere to just take a moment. And can you recall the last thing that you feel like you did really, really, really well? And if you would, just give me a little wave when you think of something. You don't have to keep your hands up. Or if you're in a room with small people, maybe just give each other a little bit of a nod. Can you recall something that you did really, really, really well recently? I'm seeing a few hands go up. I certainly hope that you can just as easily get to remembering something you've done really, really well as you can any errors that you may have made. Because the likelihood, given the statistics of DVT, is that you have encountered, maybe lost sleep, maybe had anxiety, or at least gone into a question about whether your actions or inactions may have had a negative impact on another human life. And my perspective is that we're in this together to make this work better. I'm not making things change, but I'm trying to, Keith, so just in case I did want to go there. We'll see if it sticks. So I want to thank you for being here today. I want to thank everyone who brought all of the speakers here together. And I specifically want to point out to you, Tammy, how much it means to me that we made that connection 2 years ago. And we had an image that day of me being here. And I want to also evoke your imaginations today. So I'm going to tell you some stories, and I'm going to invite you to try to be with me 6 years ago. 6 years ago, on this very day, June 12th, my husband was moving from the hospital that had been caring for him after his traumatic brain injury to the rehabilitation center, all part of the same system, but we were going to be relocating. And there were definite big red flags, and it was a hard day for us, but we made it through it, and we both just imagined a day when we'd be walking in the park again, when we'd be traveling the world again. Let me tell you just a little bit first about our family. I can't do this work, I can't come here to talk with you without the explicit and blessings of my family and his family and our combined family. And we are a unified front in terms of the work that we do on behalf of healthcare advocacy. And I know the word patient advocacy gets used a lot, and I don't want to say that that doesn't have meaning for me, but for me, it's healthcare safety, because your lives are just as much at risk as anybody else's, from my perspective. My husband was anything other than ordinary. He liked to use the word other than usual. He was an other than usual man, and we had an other than usual life. We traveled the world. We had a pretty big age difference. We didn't really concern ourselves with that too much. He was an author of a couple of books. He was an artist in his early days. He traveled the world, as I mentioned. He had a teacher in India who gave him the title Yogi Raj. And so if you hear me use the word Yogi Raj and Charles are the same person. And sometimes it's a little hard for me to go back to the word Charles, which he was also very well known as. He was the father of these amazing kids, and we have 8 grandchildren. He was a son, a brother, uncle, a son-in-law. He was a stepfather to my son, Evan. He was just this extraordinary man. And what I loved about him so much is that he just knew how to love. And he knew how to love those caregivers in those 13 days. And it was quickly known that he was hosting the most peaceful room in the hospital for those 13 days. People would come and sit. So if you could just imagine for a moment coming into our room and greeting us, so that when you hear my story today, you'll be able to meet us both then and now. To stop the clot, I think there are a few things that are going to be important. But first, let me get to what I know you'll want to hear about, and that's what was going on with him. He had a stroke after about 7 weeks of a very slow bleed, which resulted in a subdural hematoma. And that resulted in a craniotomy, which lasted about over 4 hours. He had had a recent diagnosis of prostate cancer. He was 69 years of age. He had a BMI of 28.9, and he had a serious oral infection. If you plug those factors into Dr. Caprini's score, which I did, and this is a true story, Dr. Caprini, and it's just such an honor to be able to be here with you today, because when I started to get some clues that what had happened was happening to others, and that this was not a hospital issue. I mean, certainly the hospital needed to do some things, but this was a systemic issue from my perspective. I started to do as much research as I could. And with the one of the first things that I came upon was the Caprini scoring system. So I got my phone out and I plugged in my little app. He would have scored a 15 on your assessment, and that would have put him in the highest risk. In other words, it was somewhere between, I think, a 6 and 18% chance that he was going to develop a clot. And so the next part of the story becomes relevant in light of that potential assessment. In this particular hospital at that particular time, and I don't know what it's like there today, there was no systematic assessment. And that, I believe, was a factor. There was also, thus, no reassessment, no formal, systematic reassessment. He did have IPCs on his legs during and just after surgery, but as soon as the physical therapist came in, they came off the legs, he got up and he walked, and he was vigilant about walking as much as he could, as much as his body would let him every day. And then that first ambulation was the last ambulation that he had, because the pharmaceutical was contraindicated, given that they were concerned that he might start bleeding again. So of course they wanted to manage that as well. He did have clear symptoms of both a DVT and a VTE, and I apologize, I am not a clinician, so if I make mistakes along the way, especially if I mispronounce something, I would encourage you to come correct me, because I actually like to say it well, but I just don't use these words every day, and so they don't come off the tongue quite as quickly as they might for you. He had pain in his lower calf. He had an elevated D-dimer. He had sudden chest pain, and his anxiety, when he would have what I called spells, it would take him hours to recover sometimes. And then he also had labored breathing. He had low oxygen saturation, dipping into the 70s from time to time. In the final days of his time there at the hospital, he carried an oxygen tank around with him everywhere he went. He had an inability to complete physical therapy a couple of times because of a collapse. And he had tonic-clonic seizures. And this is one of those places, the tonic-clonic seizure. I want to say that there was a lot going right in this hospital. They were very attentive, and that tonic-clonic seizure was alarming to them. They were giving it the utmost of attention. But what do you think they were looking for? He'd had brain surgery, so of course they were looking for what could be going on in the brain. Is the seizure medication working properly? So on and so forth. So remember again, these individuals were giving good care in many, many ways. And unfortunately, the care that they were not giving, or the misses that they were making, were going to overshadow all that good care if we let it, and I refuse to let it. For me, to stop a clot, I think there are three main things, and I'm just going to say this before I get into the story. I think we need to increase a continuous assessment for both DVT and PE. We need to increase a system-wide education program, and we need effective utilization of DVT prophylaxis. If those three things happened, I am quite certain that DVT would decrease significantly. So I got connected with two organizations after I learned that my husband had died from the most preventable cause of hospital death in the United States and in other countries as well. And the Minnesota Alliance for Patient Safety was the first organization. If anybody in this room knows Marie Dotseth, she is an absolute angel, and she helped me walk through what I didn't even know was an industry called patient safety. What I didn't even know was an issue when we walked into the hospital, quite naive, not even realizing that complications. I mean, of course, I knew that this was a serious matter, but we didn't have a clue. We just didn't know. We were very, very naive, and we were very hopeful, which I think was a good thing, but it didn't save my husband's life, unfortunately. The second organization was the Patient Safety Movement Foundation, and that's how I got to know Tammy a couple of years ago when I was speaking at one of their events. And I soon after that joined they have these things called actionable patient safety solutions. There are 16 of them. Many of them have sub-apps, they call them. And I sit on the work group for the VTE as well as the patient family engagement. And a few of your colleagues here also have helped develop the actionable patient safety app, the actionable patient safety solutions, which are evidence-based, researched, very, very well-documented recommendations. And I hope that if you haven't seen this document, you will go to the website, the Patient Safety Movement Foundation's website, look up Actionable Patient Safety Solutions, and if you pull up DVT, you'll be able to see the recommendations there. I'm not going to go into that today because I'm sure that you're going to hear a lot about that. I really want to tell you our story. So why does HAVTE persist despite prevention advancements in risk assessment, in prevention with pharmaceutical as well as mechanical and non-mechanical devices? There have been advancements in detection methods. There have been advancements in system protocols. One would be hard-pressed to Google. Even a non-clinician like me can go into Google and get pretty quickly updated on the elevation of attention and really good advancements on both preventing DVT as well as addressing it when it occurs. So why does it happen? And I want to propose to you that there are 6 parts of our experience that may offer you some clues. So again, I'm going to ask you here in the room and those of you who are watching later or listening from rooms abroad today to really use your imaginations and try to join us. But first, I want to go for a little bit of a hike. So I like to go for hikes pretty much everywhere I go. Today I'm going to go up to the top of Mount Washington, which is, I understand, one of the coolest things to do in Pittsburgh. And I don't know if I'll encounter snakes there or not, but you can be willing to bet. You can be willing to bet that if I do encounter a snake, one of the first things I'm going to ask is my life in danger? Could this snake be poisonous? Now, the truth is, most snakes are not poisonous, right? I think there's maybe even less than a handful of snakes that are actually poisonous. But I want to propose to you that if you take the list of symptoms that are associated with DVT and PE, and you put them into your high level of suspicion, and you look for DVT and PE, that in and of itself would probably mitigate a number of either fatalities and I also just want to recognize that although my husband died from his PE, many people have lifelong suffering. The likelihood that the individuals who are watching right now have had a personal, in addition to your professional experiences, is really, really high given the numbers. And so the high level of suspicion is warranted from my perspective. The actionable patient safety solution says it like this, that although patients with acute PE typically endorse shortness of breath, tachypnea, or tachycardia, sudden cardiac arrest is the first symptom in 25% of PE patients. And because of that, one must maintain a high level of clinical suspicion to diagnose VTE. And they go on further to say that really the best thing to do is to stop the clot, is to prevent that DVT from happening in the first place. And so I am so encouraged when I come to organizations like this who have signed on and said, yes, we are going to look at that, we are going to address that. So again, I want to let you know that that clot was forming, and while it was forming, everyone was paying attention to my husband. They were not only paying attention to him, they were actually paying attention to me as well. When they brought water, they brought 2 waters. They knew I wasn't leaving the hospital. They got over the fact that finally they started bringing me a bed. And they were caring for us in the absolute best possible way that they could. But what was not happening was a connection. From my perspective, there was not an education system-wide. I will give you a quote that my husband gave a physical therapist one day, which makes evident my point. He said to the physical therapist, "I'm going to need a calf massage after this." Those are his exact words in his medical records. Now that physical therapist was doing a lot well. And I hope today that, like you, he can get to what he's doing well really quickly. But he was also missing something right in front of his face. He was missing a clot that was forming, that was getting larger, and that was going to shut down my husband's life. So that education was just simply not evident from our perspective in that particular hospital at that particular time. And I propose that if it had been, if there had been education, not only would that PT have been able to help make that connection, but I would have been able to make that connection. I got a book, and I am not exaggerating here at all. I should probably bring it as a prop, but I came all the way from California. It was no less than 3, I don't know, maybe 3, 4, or 5 inches. It was a very thick book with hundreds of pages, and I read it. I was a very, very, very good wife, and I read that book. And it was for traumatic brain injury, right? Probably produced by the neurosurgery team, I would imagine, and their communications team. Not one single word in that book about DVT or PE, not one. Not one single word. That tells me that there was not a system-wide education. There wasn't a priority of education around DVT and PE. So again, when you say that as an organization, you're on this, it gives me such comfort and makes me feel like this doesn't have to be forever. So I'm going to ask you a question, and I do want you to raise your hands high, if you would please, if you can say yes to this. Do you believe that you can stop the clot? That is awesome. I hope that those that we can't see here today, I will say that almost everyone in this room raised their hand. Believing that you can do it, I think, gets you really far down the line in being able to make that happen. The third part, I do want to give you some words. So I don't know if you're going to like these words or not, but I'm going to ask you to at least take them as maybe a straw man and work them a little bit. If you can imagine coming into our room and we're just chatting, my husband's probably trying to watch a movie and I'm saying, no way, honey, that's just not going to work. And he's like, you're right, it's not going to work. Let's get up and walk again. You come in and you say to us, while we do our best to help heal, complications can occur as a result of hospitalization and surgery. And DVT is one such potentially life-threatening complication. Be on the lookout with us. If we had heard those words, I absolutely triple guarantee you that we would have been on the lookout with those practitioners. Absolutely, we were ready to be partners in the care. Now, I know not everyone has the presence of mind to be able to do that. There are other complications. But if you said that to each other, if you said that to anyone who comes into your room, I think it could make a difference. So maybe try on those words or some version of them, see what works for your organization. I'll tell you another story. It's Father's Day, and I wake up and my husband is in the middle of a tonic-clonic seizure. His head is turned far to the right, his arms are up in the air, and he's mumbling something, and I go into panic. Of course, I scream for help. Code blue happens, the room fills, and before I know it, we're back where we started from, in the emergency department. And for hours, they're looking for where to place him and how to handle this, what might be going on with him. And again, they were doing so much right. They had technology. They carted in an ultrasound because they needed to place another line or I don't know what you call it, shunt, I guess, maybe in his arm. A what? Well, no, in the arm, just like for a, yeah, okay, a PICC line. Sorry, I'm going to argue with the clinicians. That's funny. They were going to try to place that back in his arm. And they couldn't find a vein, and so they used an ultrasound to help them place the vein. Has anybody here done that? You know about that? So I have often wondered, what would it have taken for that technician to take that wand and move it down a couple of feet to my husband's legs? What would it have taken for that technician to have the education and a high level of suspicion to think, this might be a clot? This might be a PE. And so the third thing that I really want to emphasize here is that we did not notice any attention given by everyone who had a line of sight to my husband's care. And I could tell you more stories. The janitor who came in and saw IPC units sitting over in the corner, the transporter who was, we had one transporter who would take my husband in the wheelchair to various appointments and things like that when he wasn't able to walk there. And one day he noticed that my husband had that oxygen tank as an appendage suddenly. And what if that person had been able to say, the person he was delivering my husband to, this is new. This wasn't there before. I wonder what that could mean. There's probably no one in your healthcare system who doesn't have a line of sight to every person you're caring for who might not benefit from knowing about DVT. Next, as I mentioned, we did not notice that there was any, and it's clear in the medical records also, that there was no systemic assessment. There was no protocol for assessment. And let me tell you why this is important to me and our family. My husband was beautiful, and he was radiant. It would be very, very hard to just do an eyeball assessment of him and think that he could be dying, that he could be developing something quite fatal. This is him with our two grandsons. On my right is our oldest son, Makai, who's now 11 years old. His Babaji is giving him a blessing. And on the other side is his younger brother, who visited us in the hospital at 3 years old, exactly 6 years ago today, on that day that we were moving from the hospital over to the physical or the rehabilitation unit. And even though he doesn't look all that healthy as much, he's showing his beautiful scar. He liked to call it his Frankenstein scar. He was still just exuding love. He did not present as a person in pain, although he did mention his calf pain, and he did have these anxiety spells, and they were hard to recover from. But boy, I tell you what, as soon as he recovered, he was one of the brightest bulbs, lights, one of the most exuberant people everywhere he went, in 8 different locations over those 13 days. I want to do a time check. I didn't see a card. Can I? Thank you. Okay. So I also want to say that prophylaxis was not updated along the way. As I mentioned, he did have during the surgery, the IPCs, and when he came back in, they came off. We started walking. You can imagine again, if you can use your imagination, we're walking down the hall. He's 6'2", I'm 5'4", and shrinking. And I am tethered to him. I am seriously, like, you probably know this better, but I didn't know this. I didn't know if I could walk next to him because he was still kind of wobbly. And they would tether me, and we would just walk, and we would walk, and we would walk. And I want to propose a couple of things that might have helped us if we had heard these. I understand that he did, and I do want to do and acknowledge, he complained about the discomfort of those things on his legs. We were never told what they were. We were never told that they meant something. We were just, it was just like, yep, they're irritating, we know that. That was it. So here's what we could have heard that might have helped, and again, this is a straw man, word crafted however you want, but I do hope that some script will be given to everybody to make this easy, make it simple, because this is actually doable. I call DVT and PE the low-hanging fruit. When you look at all of the preventable medical errors that can happen in a healthcare system, because the solutions are there. It's just the information's not, the connections are not being made. So here's what we could have heard. If you imagine, can you imagine saying this to me and my husband? I know this is uncomfortable and I'm really sorry for that. This is a potentially life-saving prescription. We need to know it's a prescription. Please let me help you understand how important this is. Or if you're that doctor, and there was one, it was one of the neurosurgeons, we're walking down the hallway, and I can see the glimmer in the neurosurgeon's eyes. He's so happy my husband is walking. He's delighted with this experience. But if he had said, hey, I heard you complaining about those IPCs today, let me tell you, it's great that you're up and walking, keep it up, but while you're at risk for DVT, those IPCs are necessary because walking is not enough to prevent a fatal DVT and PE, and that's what they're doing. They are there to help save your life. Lastly, the contraindication did not elevate an observation for DVT. So here we come full circle, I think, over to that high level of clinical suspicion. If there had been an elevated attendance to it given the contraindication, making sure that that prophylactic care that is also successful, those IPC units, they don't do nothing. And as you'll probably hear from some of the other doctors today, there are actually some great trials saying they do quite a lot. So let me just leave you with this if I would. First of all, I just want to say this does matter. What you're doing here matters a lot. And I'm going to be really, really looking forward to the day when I can call up somebody from your team and hear those words. It's made a difference. Our numbers are dropping. We got close to zero and we're sustaining it. And not only that, but we're now telling other organizations about that. We're talking about it at conferences. But I'll leave you with one last thought, and I mentioned it before. I think if you really want to stop the clot, it's going to be important to look beyond the vein. You're going to have to look at other places where you may have an accumulation of, you fill in the blank, what's yours? Accumulation of resistance, doubt, fear, disappointment with all of the failures, even amidst all of the successes that you've had in your career. There's probably some place that is going to keep you from being able to be at your best when you approach this audacious goal. And I hope that you will treat that as equally important as a clot might be developing the vein, because it will be very, very helpful for you to clear that accumulation. I use the word catharsis. My business and my process is around catharsis. Whatever that accumulation may be of your own suffering, remember that you're doing a lot right, and please, if you can, be attentive to your own care while you're caring for others. Thank you.